Hello, everyone, and welcome to today's webinar, Molecular Syndromic Panel for Rapid Diagnostics of Urinary Tract Infections. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Curetis. To learn more about our sponsor, please visit curetis.com. Now, today's event is interactive, and we encourage you to participate by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We will answer as many of your questions as we have time for at the end of the presentation. Also, if you experience any technical questions, you may utilize this Q&A box and we will assist you directly. I would now like to welcome our speakers, Dr. Huan Wang, Clinical Application Specialist, Curetis, and Dr. Matthias Klein, Principal Scientist, Curetis. For complete biographies on our speakers, please visit the Biography tab at the top of your screen. Dr. Wang, Dr. Klein, it's so wonderful to have you today. You may now begin your presentations.
Thank you for your kind introduction. Hello, everyone. My name is Huan Wang. I'm currently working as Clinical Application Specialist at Curetis. I'm pleased to be here today to discuss urinary tract infections. I will be talking about the etiology of urinary tract infections and the diagnostic method. Afterward, my colleague, Dr. Klein, will take over to detail culture method and innovative diagnostic tool, molecular syndromic panel. A UTI is an infection affecting any part of the urinary system, including the kidneys, ureters, bladder, and urethra. The urinary tract has a portal to the outside, making it easy for microbes to enter the urinary tract. Because urine is a good medium for bacterial growth, many bacteria can grow in the urinary tract. Women are at greater risk of developing a UTI than men due to a shorter urethra. Pregnancy and menopause also increase the risk of urinary tract infections in women. Over half of all women will experience at least one UTI in their lifetime. Other risk factors include previous UTI, sexual activities, poor hygiene, medical conditions such as enlarged prostate, kidney stone, diabetes, and catheterization. UTI is one of the most common bacterial infections, contributing to significant healthcare costs and mortality worldwide. In 2019, there were approximately 405 million cases worldwide, leading to 236,000 deaths in both men and women. The increased cases and deaths from 1990 to 2019 are likely caused by increasing antibiotic resistance and the aging population. The estimated total societal cost in 2017 in the US reached nearly 5 million, including direct medical costs such as hospitalization and indirect costs such as time off work. UTIs are usually classified as upper or lower according to where they occur along the urinary tract. The inflammation usually begins in the lower urinary tract. Lower UTI include infections of the bladder, cystitis, and urethra, urethritis. If bacteria move upward, they can cause infections in the upper tract, such as ureteritis in ureter, and pyelonephritis in the kidney. Depending on the factors that trigger the infections, UTI can be classified as uncomplicated or complicated UTI. Uncomplicated UTI generally occur in non-pregnant, healthy women with no structural or functional urinary tract abnormalities. Patients normally experience frequent and urgent urination. They may have blood and pus in the urine and experience pain or burning sensation during urination and suprapubic pain. Complicated UTI occurs in pregnant women or men, patients with comorbidities such as diabetes, or patients with abnormal anatomy, for example, those who have urinary obstruction or renal diseases. And patients with indwelling urinary catheters are also prone to develop complicated UTI. So complicated UTI cause syndromes as uncomplicated UTI, but it can also have more severe symptoms such as fever, chills, flank pain, nausea, or vomiting. For elderly patients, UTI can cause nonspecific symptoms such as acute mental status changes, new onset of confusion, or worsening of confusion in elderly individuals are often associated with urinary tract infection. Cystitis, pyelonephritis can be uncomplicated or complicated depending on the risk factors we have talked about in the previous slide. Either uncomplicated or complicated UTI can occur again. The recurrent UTI is defined as at least 3 times UTIs per year or 2 times UTI in the last 6 months. Some patients may need to have a catheter inserted into the bladder through the urethra to drain urine. And the urethral catheters can directly inoculate organisms into the bladder. When a person develops UTI during catheterization or has had a catheter in place within the past 48 hours, it is called catheter-associated UTI. The presence of a urinary catheter is the most important risk factor for urosepsis. Catheter-associated UTI increase the patient's length of stay in the hospital with high morbidity and mortality, and increase the healthcare cost. In the US, catheter-associated UTI is responsible for 70 to 80% of complicated UTI, accounting for 1 million cases per year in the United States, and 13,000 deaths are associated with UTI each year. Complicated UTI has a higher risk of leading to urosepsis. Sepsis and the associated inflammatory response can lead to multiple organ failure and death. Urosepsis accounts for 9 to 31% of all sepsis cases and has a mortality of 20 to 65%. E. coli accounts for about 61% of urosepsis cases. Uropathogenic E. coli are the main pathogenic factor for UTI, accounting for about 75% of uncomplicated UTI cases and 65% of complicated UTI cases. The bacteria colonizing the urinary tract in most cases do not cause disease because the host can rapidly remove bacteria from the system via urination and host immune response. But some bacteria have special features that can enable them to survive in the urinary tract. For example, E. coli can colonize the urinary tract using a variety of virulence factors. The virulence factors include structural components such as pili, as well as secreted toxin and iron acquisition system siderophore. Escape pathogens are another group of urinary tract infection-causing organisms. Escape refers to the 6 pathogens: Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumonia, Acinetobacter pneumonia, Pseudomonas aeruginosa, and Enterobacter species. Escape pathogens can colonize catheters and build biofilm on them. Biofilm can protect them from the immune response attack as well as antibiotic treatment. Therefore, escape pathogens are difficult to treat. Those organisms are becoming increasingly resistant to many antibiotics, including fluoroquinolone, 3rd and 4th generation cephalosporin, aminoglycoside, and even carbapenems. Candida live on the skin and inside the body, such as in the mouth, throat, gut, and vagina. They can cause fungi infections and bloodstream infections. Candida albicans and Candida aureus can also cause UTI. Candida albicans is the most reported species in UTI. Candida aureus has been rapidly emerging to become a global risk in clinical settings and was declared an urgent health threat by the Center for Disease Control and Prevention. Between 30 to 60% of the people who get infected with Candida aureus end up dying, because Candida aureus is resistant to many antifungal drugs, including fluconazole. It is difficult to identify with standard culture method, and it can be misidentified as a number of different organisms. And the misidentification then lead to inappropriate antibiotic treatment. Candida aureus affects ill or immunocompromised patients. It is highly transmissible between patients through contact with contaminated surfaces or objects in healthcare facilities, because Candida aureus can live on surfaces for a long period of time. Proteus mirabilis is part of the normal gut microbiota. It is an opportunistic pathogen that can cause infection in patients with weak immunity. Proteus mirabilis has high active urease, which is important for colonization of the bladder and kidney, and promotes the formation of stone. It also has a notable multiple drug resistance through beta-lactamase production. Streptococcus agalactiae is group B Streptococcus. It is a commensal bacteria that colonize the urinary and gastrointestinal tract of healthy adults. It has shown increasing penicillin resistance. Streptococcus agalactiae is also a opportunistic pathogen for newborn, elderly, and immunocompromised patients. Because group B Streptococcus is the main cause of neonatal sepsis. Therefore, for a polymicrobial sample that normally would be rejected, should be conducted a urine culture for the identification of Streptococcus agalactiae. Other unusual or rare or fastidious bacteria may also induce UTI. Those bacteria often go undetected in commonly used culture media. Such organisms should be checked for patients with urinary symptoms and pyuria, that is when you have pus in your urine. Even when the routine cultures are reported to be negative, such organisms should be checked. For example, for renal transplant patients who show symptoms of UTI, but the urine culture is negative, they should be tested for Corynebacteria urolithecum because Corynebacteria urolithecum commonly found in the urogenital tract of human. It is rare, but the actual prevalence is probably underestimated. It is also a multi-drug resistant organism. Another group of causative organism for the UTI is anaerobic enterotypes such as Bacteroid, Prevotella species, which are part of the microbiota. They are prevalent in urinary samples at low concentration level. When patients show persistent symptoms after taking the first-line drugs such as fosfomycin, nitrofurantoin, trimethoprim, sulfamethoxam, but the culture remains negative, the physicians would then need to request anaerobic culture. The fastest and simplest diagnostic test is a urinalysis, which analyzes a sample of your urine looking for bacteria and blood cells. The doctors often carry out dipstick tests, in which a chemical strip detects an enzyme called leukocyte esterase that points to the presence of white blood cells. The dipstick tests also detect nitrate, which are a waste product from the breakdown of certain bacteria, such as gram-negative Enterobacteriaceae. However, Staph and Enterococcus do not produce nitrate, so we may be missing them just on dipstick alone. Therefore, in many healthcare settings, urine dipstick testing are no longer performed at the point of care. Instead, urinalysis is done in the clinical laboratory using microscope and some automated instrument, such as flow cytometry, urine sediment analyzer. A positive urine culture is defined as 10 to the power 5 colony-forming unit of microorganisms per milliliter of urine. To identify the cause of the infection in positive samples, the clinical microbiology laboratory will culture urine on agar plates for growth, identification, isolation, and concentration. Common pathogens such as E. coli and Enterococcus species are easily identified with the use of chromogenic agar or some biochemical test. For the identification of other species, MALDI-TOF, mass spectrometry, and PCR are often used. In addition to the identification of pathogens, knowledge of antibiotic susceptibility of an infection is essential to provide appropriate antibiotic therapy. AST, antimicrobial susceptibility testing, is a phenotypic assay that measures bacterial growth in the presence of specific antibiotics. This can be done by conventional manual methods such as broth dilution, disk diffusion, or can be done by automated instrument. Urine culture provides a definitive diagnosis for targeted antibiotic therapy because it provides pathogen identification and resistance susceptibility profile. This can also be achieved by molecular diagnostic platforms such as multiplex PCR, because multiplex PCR panel can also identify pathogens and detect resistant genes. The initial screening of UTI by urinalysis takes about 1 to 4 hours. As mentioned earlier, dipstick or microscope could be used as the screening tool. Combined with the clinical symptoms and the finding of blood cells, pathogens in the samples, patients are given empiric treatment with first-line broad-spectrum antibiotics such as penicillin, beta-lactam, cephalosporin, fluoroquinolone, and carbapenem. To find out which bacteria is the culprit and what is the proper antibiotic to treat them, ID identification and AST antimicrobial susceptibility testing are performed. The pathogen identification typically takes 24 hours. For first-tier pathogens, the identification can go beyond 24 hours. For pathogen isolation and identification, antimicrobial susceptibility testing takes an additional 24 to 48 hours. Once culture results are available, broad-spectrum empiric antibiotics should always be switched to a targeted narrow-spectrum antibiotic. This is essential to avoid unnecessary exposure to broad-spectrum drugs and combat resistance. Over the years, we have seen a rise in multi-drug resistance organisms due to the over-treating and overexposing the patient to broad-spectrum antibiotics before the culture result become available. This resistance makes treatment more complicated and costlier. In summary, diagnosing and managing UTI effectively is crucial, particularly with the rise in multi-drug resistant pathogens. I will now turn over the presentation to my colleague, Dr. Klein, who will dive deeper into culture method and the molecular syndromic panel that support UTI diagnostic. Thank you.
Okay, thanks Huan for this overview on urinary tract infection. My name is Matthias Klein, and for the second part of the webinar, I will guide you through. So the second part of the webinar will explore current lab practice in more detail and discuss how molecular syndromic panels could contribute to improve patient management. But let's first take a closer look into current lab practice. The first thing you do, and you heard this from Huan, when a urine sample arrives in the lab, is plating. Here you use aerobic selective culture media for different types of organisms, like for gram-positive or gram-negative bacteria or fungi. Larger labs often apply here a certain degree of lab automation, for example, using a Copan wasp or a BD Kistra. The identity of organisms is typically determined by MALDI-TOF, and antimicrobial susceptibility tests are performed by devices like VITEC or microscale. We have different types of samples. So the most common one is the clean catch midstream urine. Others are catheter-related urine or suprapubic urine. For those who are not familiar with the term suprapubic, that means such samples are drawn via a catheter, which is directly inserted into the urinary bladder. And such sample types also determine the clinical sensitivity required for identification of putative causative organisms. But this is a more complex issue, and we're going to talk about that in a few minutes. So one common method is the use of preservation agent for collected urine samples. Microbial quantities and their relations to each other are very important for result interpretation. However, urine is a gross medium, we also heard that before, and microbial quantities may change during prolonged storage, so such samples may even overgrow. As a rule of thumb, samples stored at ambient temperature should be processed within the first 2 to 4 hours. For refrigerated samples, this can be extended for up to 24 hours. So typically, many labs use preservation agents like the BD Vacutainer, which is the most prominent supplier. Such tubes include boric acid and other salts that preserve microorganisms in a way that they remain viable and can still be cultured, but prevent any growth, so the different microbial quantities remain mainly unchanged. Such preservation tubes allow ambient storage for up to 48 hours. Now, result interpretation is a complex matter, and you can probably already imagine that when you just look at the slide. It starts with the lack of generally acknowledged guidelines. There are some like CUMI-TAG or ASM, but they're all a bit different, and there are many more operating procedures out there at different hospitals using their own clinical cutoffs and different rules of interpretation. One main factor for consideration is the used sample type, and we talked about that already. Others are the patient conditions and the ID of the detected organisms. One main factor is also the number of different organisms or morphotypes with levels above clinical cutoffs observed on your culture plates. And in case you find more than one, the question is which are the predominant ones and which are the clinically relevant ones that merit treatment. Therefore, this table shows you several rules how to proceed if you observe 1, 2, or 3 or more different morphotypes, and how to proceed either by doing a full identification and AST, or by reporting morphologies only, or even by rejecting the samples. So there is no need to read through all of these. This is illustrated on the next slide with some practical examples. So on the left side, you see some even more sophisticated rules, but have a look to the examples on the right side that present a more simplified view of typical outcome scenarios. You may, for example, observe multiple organisms, but all at levels at or below your clinical cutoffs. And I can tell you, the more sensitive you try to be, the more you will probably detect. Urine specimens contain urinary tract flora at a variable extent. And this is what you see in example A. So this is a negative result. Unfortunately, possible causative organisms and typical flora organisms show quite some overlap. So having the ID alone in many cases does not really help you for discrimination between the relevant and the not so relevant ones. In example B and C, you see scenarios of either 1 or 2 organisms are not only above clinical cutoffs, but also show quantities way above the quantities of the other organisms. Such predominant organisms are then typically considered clinically relevant or possibly causative. I think the most common outcome of a urine culture is that one organism is reported as clinically relevant, like in example B, and oftentimes this is an E. coli. But what happens if you encounter 3 or more organisms or morphotypes at high concentration? Now, the common practice here is to reject such specimens, discontinue and abandon identification AST at all and request to recollect a new sample. And why? Because such samples are considered either contaminated with large quantities of flora or might have been overgrown during storage and should not be used for diagnosis due to a low prognostic value. From our own studies, we observed the following distribution of standard of care culture reporting outcomes. For about 1 quarter, no growth is reported. For another quarter, there is only urinary tract flora reported. For about 1/3, one single organism or one single predominant organism is reported. Only for less than 10%, 2 organisms are reported. And also for less than 10%, there are 3 or more, leading to a sample rejection. We also did studies to compare standard of care lab culture results with full aerobic culture, meaning that all observed organisms are reported here regardless of any relevance. And the number of the observed organisms between these 2 approaches differed by a factor of 6. And we did not even try to hunt down the anaerobic bacteria or the fastidious organisms. If so, the ratio would even be worse. So in conclusion, standard lab culture reports only a small amount of what is actually present in the sample. And of course, this comprises also the rejected samples, all those organisms reported as flora, but also the organisms either not predominant or not considered relevant. One extreme examples are the coagulase negative staphylococci, CNS. They are actually encountered in urine samples quite frequently, but only 1 case of 50 about makes its way actually to a micro report. So in summary, result interpretation is challenging. So how to identify the ones with a putative clinical relevance, which are often the predominant ones, how to discriminate from overgrowth and contamination, when to reject a sample due to its low prognostic value, and all of these questions need to be answered in the light of the clinical context, the sample types, and the organism IDs. But let's move on now to the molecular syndromic panels. The basic idea of such panels is that you are going to screen for all relevant microorganisms, ideally together with associated antibiotic resistance markers for a multifactorial disease syndrome. And you see some examples of such syndromes on the right side. Such simultaneous assessment will be allowed by using multiplex PCR, so thereby allowing comprehensive conclusions on possible causative organisms and alerts on possible presence of resistant phenotypes in a considerably shorter time frame compared to culture. Now, what are the requirements for UTI syndromic panel? Of course, all of the common organisms and associated resistance markers should be covered. But molecular assays now also open up the possibility to detect fastidious organisms, hard to cultivate organisms, or anaerobic bacteria. So any of such organisms that are not searched for in the first place, but only on special request. So in case your culture plates remain still empty, but the condition of the patient is still worsening. Huan talked about several of such organisms already in more detail in the first part of this webinar. So we have Strep agalactiae, an important risk factor. We have CNS and Candida, overlooked or not reported. We have Corynebacterium urealyticum, a fastidious organism, or anaerobic bacteria like Bacteroides and Prevotella. So furthermore, some sort of semi-quantitation is also preferred, of course, to support identification of predominant organisms. And finally, nobody wants to pipette thousands of PCRs. An automated solution with reduced hands-on time and decreased risk of contamination is absolutely essential. This next slide shows you the indications of use. So when to use a molecular panel, when it is indicated. In general, always whenever we also would order a culture. So this is mainly for the CUTI, hospitalized, severely ill patients. A molecular panel would aid in the diagnosis, but it's not a standalone method. Culture should always be performed in parallel. On the other side, use is not indicated whenever also culture is not indicated. That is for asymptomatic UTI or for uncomplicated UTIs for which an empiric treatment is already considered sufficient. It would also be not useful to screen healthy populations for risk factors, for example, screening pregnant women for a possible undiscovered presence of UTI to exclude pregnancy risks. So the next slide shows us a comparison between the traditional culture and the molecular panel. Traditional culture has a long time to result, allowing therapy adjustment only after several days. Once results become available, it may not detect or overlook fastidious or anaerobic organisms or polymicrobial situations. Inadequate and delayed antibiotic therapy may lead to an increased length of stay for the patient and even to an increased risk of comorbidities or fatalities. On the other hand, a syndromic panel provides results within a few hours, requires minimal hands-on time, covers all panel organisms, and simultaneously includes the resistance markers. Therefore, it may allow an earlier appropriate therapy or a rapid therapy adjustment. Now, for the last part of the webinar, I would like to introduce to you a molecular panel for UTI, which is till now the only one available on the market with a CE mark, Unyvero UTI. This is a platform using a closed cartridge-based system, applying endpoint PCR and subsequent array hybridization. The platform consists of a lysator unit for sample processing and an analyzer unit. So the lyse sample and the polymerase master mix tube are inserted into a cartridge, and this cartridge then gets inserted into the analyzer unit. The whole process is guided by a cockpit, which provides a barcode scanner to track cartridges and patient samples, and which displays the final results. And comprehensive results are then available in about 4 to 5 hours. Unyvero UTI is intended for CUTI patients. It allows direct processing of patient samples, the simultaneous detection of microorganisms and associated resistance markers, is based on PCR assays, and is to be used in conjunction with urine culture or other lab methods. Target customers are microbiology labs or hospital labs. And this is how the panel looks like. You find all these common organisms, required, of course, to achieve an expected organism coverage of more than 90%. But you'll also find those special ones, so mentioned before and highlighted in green here, like CNS, Strep agalactiae, Corynebacterium, Candida, and so on, together with relevant associated resistance markers, here highlighted in a blue box. The panel includes resistance markers associated with gram-negative bacteria like Enterobacterales and non-fermenting bacteria. In this case, this is Pseudomonas or Acinetobacter. We have CTXM conferring resistance to third-generation cephalosporins, several markers conferring resistance to carbapenems, but also QNR genes for quinolone resistance, or SIL1 conferring resistance to sulfonamides like in 3-metoprim sulfamethoxazole. On the gram-positive side, the panel comprises Wang genes relevant for vancomycin resistance in Enterococci, or MAC-A relevant for methicillin resistance in Staphylococci. Results from microorganisms are presented as a qualitative yes-no result, but together with 3 bars reflecting array signal intensities. So this may help you to identify predominant organisms. The following slide shows results from a clinical evaluation study we had performed at 5 European sites. Clinical sensitivity and specificity were quite promising, but I would like to point you to the positive predictive value, and an issue you will typically encounter whenever you compare a molecular panel to a culture reference. You detect and report much more compared to your reference. The positive predictive value is the percentage of the detection by your investigational device, which had also been reported as positive by the culture reference. So a PPV of about 50% means that Unyvero UTI reported about twice as much organisms compared to culture. And again, this is due to the sample rejections, the polymicrobial situations, flora, not considering organisms as relevant, or overlooking hard to cultivate organisms. Presence of the vast majority of such additional findings was successfully confirmed during discrepant result resolution. So such findings were actually true. Oftentimes, such organisms are even present at large quantities. And subsequently, the PPV post-discrepant result resolution is then also way above 90%. The next slide summarizes the detected resistance markers together with reported possible host organisms and their phenotypic agreements. Well, for the resistance marker, it needs to be noted that there is no definite linkage provided or confirmed, so the simultaneous reporting may be coincidental, and such markers may originate also from other sources, from other organisms, or from flora. However, if a marker together with a host organism is reported, it alerts the user of a possible therapy failure. On the other hand, if the organism is detected without any marker, you cannot conclude on susceptibility, as resistant phenotypes can also be confirmed by other markers or mechanisms not covered by your panel. Now, how can a molecular panel support patient management and antibiotic stewardship for UTI? So rules for reasonable antibiotic stewardship for UTI are to avoid unnecessary prescription, to order culture only when signs and symptoms are present, and to prescribe antibiotics based on susceptibilities and only for the recommended duration. In the first part of the webinar, we presented you already the first version of this slide. So patients are treated empirically on day 1, and therapy gets adjusted only after several days once culture results become available. Now, with a molecular panel included, you may be able to select a tailored narrow antibiotic therapy already on the first day, which helps you to improve patient management and also supports antibiotic stewardship rules. So we have now reached the end of this webinar, where we hope we have shared some interesting and valuable insights. Huan and I would like to thank all listeners for joining in, and we are happy to answer your questions. So thank you very much for your attention.
Dr. Klein, Dr. Wang, thank you so much for your informative presentations. To our audience, we will now start our live Q&A portion of the webinar. So if you have any questions you'd like to ask, please do so now. Simply type them into the Ask a Question box located on the left of your screen, and we will answer as many of your questions as we have time for. So let's get started. I'd like to just dive into these questions that have already been submitted. So let's start here with this one. You have outlined the advantages of syndromic panels for UTI. Could you share what the potential limitations would be?
Yes, of course, syndromic panels will also have some limitations. I think the first one is the size of your panel. As said, it should include all of the frequent ones and all of these special ones, but it can never include all organisms that are around. So you will detect only those organisms which are part of your panel and not the others. I think another important limitation are the antibiotic resistances. So there are many resistances which are conferred by the presence of one specific resistance marker gene, and you can screen for the presence or the absence of such a gene. But there are also other resistant phenotypes which have a more complex origin. I think a good example for UTI would be resistance to nitrofurantoin. So nitrofurantoin resistance is conferred by a number of different single point mutations in a number of different genes. So that resistant phenotype is not accessible by a molecular panel in a reasonable way. And yeah, and finally, we also talked in the webinar already about you cannot conclude on susceptibilities from their antibiotic resistance markers, and there is also no definite linkage between a marker and a possible host organism. They could be coincidentally reported. So, and this is a bit of a difference to a traditional culture where you will get your culture isolate ID and the associated phenotype, which is definitely linked to each other.
Thank you. Our next question, what impact on routine diagnostics do you anticipate when introducing molecular panels?
Right, I'll take this question. So one of the most immediate impact of introducing molecular panel is a significant reduction in time to result. Because as Matthias mentioned that molecular panels can identify pathogens and detect resistant genes within few hours compared to traditional culture that can take up to at least 48 hours. Secondly, due to the high sensitivity and specificity of the molecular panel, the molecular panel could detect pathogens that traditional culture might miss, especially in the case of fastidious or slow-growing organisms. Therefore, this quicker and more accurate identification allows for a faster and more targeted antibiotic treatment. This will potentially improve patient outcome and support antibiotic stewardship. Of course, there are also considerations about the potential challenge in the result interpretation and the cost. So it will be important to integrate the molecular panel carefully in the current workflow, combining with the traditional culture to ensure that they support each other, they can be used for an appropriate and effective routine test. Thank you.
Thank you, Dr. Wang. And our next question, do you think that molecular assays could replace traditional culture in the future?
Yeah, maybe I'll take this question again because it's a little bit of follow-up of the previous one. So we talked about all of these limitations, and I think with these limitations in mind, the answer is already, it's a clear no. No, a molecular panel should be also always performed in conjunction with traditional cultures and should not replace it. So it complements actually the culture by providing data at the very first day, but it will never be able to replace culture totally. So yes, the answer is clearly no.
Very good. Thank you very much. And we do have time for one more question. What if the culture results don't match Univero's results?
Yes, I think we had this in when I showed this clinical study data and I talked about the positive predictive value. So it's obviously clear that in many cases the molecular panel will not match or not fully match to the culture results. But I think this is a more fundamental issue relevant for all molecular panels in general, because it's not only the results are different, it's a completely different type and quality of results. So, for example, for traditional culture, you get your culture ID, you get the associated phenotype, and from a molecular panel, now you get information on the presence or absence of relevant target genes. So this is something different. And I think this has a different quality. And I think culture users need to get accustomed or acquainted to such different type of results and learn how to interpret these and use them in their daily routine. So does this answer this question?
Very good. Thank you so much. And Dr. Wang, Dr. Klein, thank you both so much for your time today and for sharing your expertise in how molecular syndromic panels support the diagnostics of urinary tract infections. I do want to thank LabRoots and our sponsor, Curetis, for underwriting today's educational webcast. Now, before we go, I do want to thank our audience for joining us today and for their interesting questions. We had quite a few questions come in, but due to time constraints, we are unable to answer them. So rest assured your questions will be answered via the email address you provided at the time of registration. Additionally, this webinar will be available for on-demand viewing, and LabRoots will send you an email when it's available for replay. You can still submit questions during that on-demand period, and we will get those answered to you. So thank you again to everyone joining us today. Have a great day, and we hope to see you again soon. Bye-bye.
Okay, thank you very much.
Thank you.